Welcome back to the Neurology Nuts and Bolts podcast, all about constructing your career in neurology. I'm your host, Sarah Schaefer from the Yale School of Medicine. Today, as part of the Finances of Practice series, we will be reprising two guests from the RVUs podcast to talk about outpatient billing and coding. If you haven't listened to the RVUs episode, I highly recommend it, as it relates very much to what we will be discussing today. Rohit Marwar is an assistant professor of neurology at Wayne State University, and Mark Newer is the department head of neurophysiology at UCLA, and serves nationally on the CPT and RUC, or RUC, Relative Value Update Committee advisory panels that publish CPT codes and set RVUs. Thank you for joining us today, both of you.
You're welcome.
Great to be here.
So I want to start with sort of a mile high view of billing and coding for anybody who might not be that familiar with this part of things. You are in the electronic medical record. You go to the billing section of your medical record system. What are you faced with? What are the general categories of things you need to consider when billing, which we'll go into more detail later in the podcast. Rohit?
I think it's important to note that these rules that we are going to be talking about today were implemented in January 2021, and it has changed a lot of things. And I strongly feel that the changes are favorable to us neurologists or other specialties that manage chronic conditions. So this is how I approach a patient when I'm seeing the patient in the clinic. So is the patient new or is the patient established? Now, new is defined as not seen face-to-face by someone from your group in the past 3 years in the inpatient or outpatient setting. And the group is defined by the tax ID that is used. If the patient is new, then you have to decide between new patient versus consultation. Figuring out which patient is a consultation can be a little tricky. This is how I remember it. A consultation needs 4 R's. First R is request from a referring provider, and the name needs to be mentioned in the note. Second R is reason for consultation, which is also your chief complaint. The third R is render, that is you give your opinion, your assessment and plan. And the fourth R is report, that you send the report back to the referring provider. Now, there are some caveats to this. So if the referring provider wants you to take over the care of the patient for that particular problem, then it is considered a new patient and not a consultation. Some practical scenarios that we encounter in our day-to-day practice. First one is, someone referred from the ER. So that is considered a new and not a consult. It could be an established also if the patient has been seen previously within the past 3 years. But the ER physician is not expecting you to send the report back to them. So that's considered a new patient. Now, a patient making a self-appointment is not a consult. A patient seen in the hospital by a neurologist in your group less than 3 years ago and coming to clinic now, that would be considered established. A patient who is seen in the ER by a neurology resident or a fellow, but was never staffed by the attending and coming to clinic now would be considered a new patient or a consult patient. But if it was seen by an attending, then it would be considered established.
The rule state by state varies as far as whether Medicaid is going to pay for consults. Usually Medicaid follows the Medicare rule, which is they don't pay for consult. If you're seeing the patient, it has to be either new or established.
That explains why consult actually doesn't come into play too much for me. I must be in a state where it's really just new or established and not necessarily consultation versus non-consultation consideration.
Yeah, and some of your commercial carriers also do not use the consult code. They will expect you to bill it as new or established.
It might help to talk to your billing and coding department. At least in my practice, if I wrongly code as a new patient when it should be coded as a consult, they do change it at the back end. So there might be corrections happening at the back end, even if you code it incorrectly.
And is that because consultations are reimbursed at higher rates?
That is correct.
We're going to dive into these in a little more detail, but I just wanted to review the language, which for me is very confusing. You know, there are all these acronyms, right? CPT, ICD, E/M or EM. Dr. Newer, can you just say what some of these things are, and then we can talk about how they relate to billing and coding?
CPT stands for Current Procedural Terminology. It's a list of 8,000 different medical, surgical, and testing services. They're categorized by a 5-digit number. That tells the insurance company and the billing folks what it is you did. Each specific visit has a different code depending on whether it's new, established, consult, observation, emergency room. Those are different families, and there are different levels of codes. When we deal with the specific codes for patient visits, we call that group of codes the evaluation and management codes, because that's what you're doing. You're evaluating the patient and you're managing the patient. It's abbreviated E&M. When you're submitting the billing for each visit, you specify which CPT was used. You also have to specify what's the diagnoses that you addressed during the visit. Diagnoses are in a publication that originates from the World Health Organization. It is modified by the U.S. Center for Disease Control, and that list of diagnoses is called ICD, or International Classification of Disease. There are many tens of thousands of diagnoses. They try to be comprehensive enough so that it is specific as to a particular diagnosis. For example, you hurt your thumb. Well, there's different codes for why you hurt your thumb, for whether it's your left hand or your right hand. It's important to get the ICD relatively correct for that patient, because when you send in a bill to an insurance company, they're going to look up what CPT you submitted, and they're going to look up what ICD you submitted. And they have lists in their computer. And those lists say, for this kind of a CPT code, only the following ICDs are allowed. For example, you can't do an EMG test with a diagnosis sore throat. When you're choosing the diagnosis codes, you also are selecting a code that qualifies as to the acuity of the patient. With that diagnosis, how sick is the patient? How important is this? How much medical attention is needed? Acuity is used in a variety of settings. Your hospital, for example, is rated on how well it does. And in those rating forms, they look at the acuity of the patients that are admitted to your hospital, and then how much has your hospital cost the insurance industry. If it's a really acute patient, they'll figure, well, it's going to cost more money to care for that patient. The systematic way of judging acuity are through what are called hierarchical coding categories, or HCC. The HCC is a ranking. If you send in a code that says cervical radiculopathy, that's going to have a certain degree of acuity. You send in another diagnosis that says cervical myelopathy, that's going to have a higher acuity. You want to choose things that are accurate, but you want to pay attention to choosing something that is not only accurate, but also has a high acuity whenever it applies. When you send in a bill, there are about 4 diagnoses that are going to appear at the insurance company from what you submitted. In your own billing system, you can submit a dozen diagnoses, but only the top 4 are going to be sent on to the insurance company. If you're going to be diagnosing somebody with an acute illness with a high acuity score, you want to put that at the top of your list. Many billing systems will tell you what the acuity is for different diagnoses. You also get higher acuity if the patient has other comorbidities that result in the patient being more complex or more acute. So if you come in and your patient has renal failure and diabetes, and you're seeing them for the neurologic complication of, say, peripheral neuropathy, you want to address the comorbidities in your visit, mention it in your note, and list it in your diagnoses. That gets the highest possibility of being recognized as a higher acuity patient. These HCC codes will be bundled together in the big insurance industry for what's called RAF scores, or relative acuity scores, risk adjustment factor, RAF. The RAF is used by a lot of HMOs to determine how much money your hospital or your university is going to get. Your HMO contracts will often say you're going to get X amount of money adjusted upward or downward, depending on how acutely ill are the patients you're seeing. It's the RAF score, the HCC scores, that determine what that adjustment is going to be. As an interesting variation on this, the relative acuity of a patient, like let's say the presence of things like heart failure, renal failure, diabetes, all those things actually are summed up in the insurance company industry over the course of, say, a year. So if some generalist has already coded renal failure, heart failure, diabetes, that's going to already include listing that patient as having a higher relative acuity factor.
Wow. So the insurance companies, even if you don't list it, if somebody else has within the past year, they actually use that information to increase the relative acuity of the patient. I'm actually kind of surprised about that, because I would think insurance companies would not want to do that.
That assumes that that patient is, or that other doctor is in your group, or that they can be bundled together with you so that it's recognized in that way. If it's, some internist from the next state over who sent it to you, sent this peripheral neuropathy patient to you, that may be a little bit too far away, and they are not being rolled into your HMO profile for that patient.
So just to sum up, so CPT codes are the codes that you put in terms of what you did with that patient, whether it was an office visit or a procedure or some other things. And EM, or evaluation and management, are types of CPT codes. And then once you bill with a CPT code, you need to link that to an ICD code or a diagnostic code. And I think right now we're using ICD-10, which is, I guess, the 10th iteration of these ICD codes, in order for those to be determined by the insurance company to be congruent with each other. And then the insurance companies use all of this information to create hierarchical acuity determinations that may increase or decrease the amount that the hospital or medical practice is reimbursed. Great. So let's talk a little bit more about the ICD codes. You touched on a lot of the decision processes involved here. My understanding from online forums and things like that is that there are some ICD codes that are, quote, billable and can be linked exclusively to CPT codes, and there are others that are non-billable. I think a lot of these are if there is a concern, a screening. For example, I know when I see patients whose family member has Huntington's disease and they want to know if they might have Huntington's disease, I put in family history of Huntington's disease, but my understanding is that that is an example of a non-billable code, and I think these often have Z, the letter Z at the beginning. Can you talk a little bit about billable versus non-billable ICD-10 codes and how you can make sure that you have a billable code attached to your CPT?
Different carriers have what I call a linkage table. Medicare, as an example, has linkage tables that are used by your local carrier, and others that are written by the national CMS. And they specify in given clinical circumstances what is payable, what is not. Those are online and available to the public to look through. They differ a little bit company to company. So if you have a commonly encountered insurance company and you are doing a certain kind of care, you might do well to look up what is the rule that is used by the computer at that company to justify whether or not you are paid.
And you talked about ICD-10 codes in terms of the maximum of 4 codes being used by the insurance carriers. I've often run into situations where, for example, Parkinson's disease, which I treat a lot of, has a lot of other codes that may be sort of related, but not necessarily exactly the same. So sometimes I put Parkinson's and REM sleep behavior disorder as separate codes, or orthostatic hypotension, or motor fluctuations of levodopa therapy, or there's a code for status post DBS placement. And I've often wondered if that makes any kind of difference, but from what you described earlier, I wonder if it may just increase how the insurances consider the acuity of that patient encounter. Is that correct?
It may well increase your acuity. And when you have several diagnoses that you did address at the visit, it may be that some of them are not on that linkage table for payment, but other ones are. All you need is one diagnosis that's on the linkage table for that kind of a service, and you get paid.
And what about, we see a lot of peripheral neuropathy and things like that, and maybe the patient has diabetes, but you're not the one actually treating the diabetes. You said that, listing other diseases that may impact the patient's acuity is important to do, but can you do that if you're not the one providing the insulin to the patient?
You need to address the diabetes in the visit. So the patient there, you check the A1C, you talk to them about how well are they adhering to their dietary restrictions, how often are they getting a checkup with their internist, something like that. And then you mention that as just in passing, one phrase or one sentence within the documentation of the visit, and that means you did address it, you can list it.
Rohit, I wanted to turn back to you as well in terms of how you go about deciding what to put as an ICD-10 code. I know that for example, if somebody comes in with hand tingling and I'm not clinically sure if it's carpal tunnel syndrome or not, and I'm sending them for a nerve conduction study, instead of putting carpal tunnel syndrome as the ICD-10 code, because I haven't yet made that diagnosis, unless it's very clinically clear, that I will put hand tingling, for example, which is less specific and potentially worse in terms of acuity. But how do you go about making those decisions?
Yeah, I think that's a good question. I think overall, the more specific you are in the ICD-10 diagnosis coding, I think the better it is. So let me give you a few examples. So, as you mentioned, actual diagnosis versus symptom. So if you're not sure what the diagnosis is, I think it's okay to put the symptom. So if you're not sure if it's carpal tunnel, you can put paresthesias or hand tingling, as you mentioned. Another example is common example is dizziness. You don't really know sometimes what's going on, and that's okay. But if you think there is a higher likelihood of a certain diagnosis, or you're confident in your diagnosis, then you can put BPPV or whatever the diagnosis might be. The other thing that Dr. Newer touched upon is, be specific about lateralization, right? Rather than just saying lumbosacral radiculopathy, mention the side. It might be right side, left side, or bilateral. Acuity is important, acute versus chronic. Whether something is active or inactive. For example, a patient you are seeing in clinic for right hemiparesis due to a stroke that happened 1 month ago, it should be billed as a history of arterial ischemic stroke with residual deficits rather than stroke, because if you say stroke, which means it's happening right now, which is incorrect. However, when you bill anything which starts with history of, it should not be the only or the first diagnosis, because that by itself might not be billable. There are a couple of oddities that I frequently run into in my epilepsy practice. So I frequently screen for vitamin D deficiency because of a lot of these anti-seizure medication have vitamin D deficiency. So when you are screening for them, you have to include a billable diagnosis of vitamin D deficiency, even though you actually don't know if the patient is having vitamin D deficiency or not, which is weird, but I think that's the way it is. When you are screening for certain other conditions, an actual screening code might be present. Again, coming back to the same scenario of using anti-seizure medications, we commonly screen for osteoporosis, and I order a DEXA scan. So when I'm ordering the DEXA scan, I put in the ICD code for screening for osteoporosis. And a lot of these screening ICD codes, they start with the letter Z. So these are, I think, some of the kind of the practical things to consider. But I agree, sometimes you just don't really know what the diagnosis is. And in that scenario, a symptom should be okay.
So instead of putting the diagnosis of osteoporosis, when you order a DEXA scan, you put screening for osteoporosis, and that may not be a billable ICD-10 code, but if you're also seeing the patient for epilepsy, that obviously would be. And so you have to kind of play the field a little bit there, it sounds like.
The less specific you are, you raise the possibility that that might be kicked out as not specific enough. And the system will say that we don't want to pay this bill.
I think another kind of a practical consideration is you don't want to be bothered by your billing and coding people about, can you be more specific about this diagnosis or change your diagnosis down the line? So I think it helps to be specific when you are actually doing it.
Yeah, anything you can do to limit the inbox messages. So Dr. Newer, I wonder if you can comment, some EMRs have cheat sheets, as it were, for what qualifies for each level of CPT code, level 1, 2, 3, 4, 5. What are your thoughts on those cheat sheets? I use them every day, so I'm hoping that they're at least somewhat helpful and accurate.
There's two ways of determining level of service for E&M. One is through medical decision making, and the other is through time. I assume that what you're talking about for these cheat sheets is either one or the other. It could be, have you listed enough of the qualifying elements for a medical decision making at level 4 or level 5? The other one could be, have you listed enough time for the use of time as the qualifying factor for determining level of service? That's helpful because it's hard to keep track of all the medical decision-making rules. We tried making the rules easier when the new set of E&M documentation standards came out last year, but I think they're still complicated.
They are, yes. Yeah, and let's talk about that. So we've talked about diagnosis codes, but we haven't talked that much about CPT codes. As anybody in the outpatient clinic knows, you choose a level for the encounter, whether that's time-based or complexity-based, as you alluded to. And then there are modifiers. Telemedicine has its own modifier. Having a trainee with you has its own modifier. I'm sure there are many other modifiers.
So let's talk first about the medical decision-making rules. You're supposed to base that on 2 out of 3 categories of medical decision-making. One is the complexity of problems. The second is amount of data reviewed. And the third is the risk of the treatments you're ordering. The complexity refers to the patient. For neurology patients in general, I like to simplify the discussion by just saying, you're really looking at, are they level 4 or are they level 5? And if they're simpler than that, they might be level 3. An outpatient at level 4 would be one chronic illness with something still to be addressed, or 2 chronic illnesses where they're really fine, there's no complaints, there's no signs, there's nothing to do. Level 5 is a chronic illness with risk of morbidity, risk of threat to bodily function, risk of side effects, severe progression, something more severe. And you have to be able to say what that is. There is a landmine buried in that, and that's the word stable. If you use the word stable, it means the clinical goal has been reached and maintained. There's nothing to do. There's no more complaining. Everything's fine. If you use the word stable for that diagnosis in your documentation, you're going to not be allowed to use that for level 5, and it's going to be harder to reach level 4. So avoid the word stable unless it truly means for this diagnosis, the clinical goal has been reached and maintained.
Wow, that's good to know as a provider for Parkinson's patients, because if a Parkinson's patient is unchanged from 6 months prior, and I don't need to make any med changes, and they're not having side effects, then I do sometimes bill those encounters as a level 3 because the patient is stable.
That's true, and that's true of a number of other medical problems that could even be acute. Somebody comes in with benign vertigo. The fact that you're using the word benign in your diagnoses may trigger an auditor to believe that you can't go any higher than level 3.
So in the situation that I just described, would you bill that as a level 4?
I would probably use time. If the time of the visit was 30 minutes, including everything that you did, review of records, review of tests, discussions with family, writing your note, doing the billing, if all the time you spent on that visit is 30 minutes, that's a level 4.
So let's talk about time, because, I work with a lot of trainees, and time-based billing gets a little bit more complicated when you have trainees in your clinic. Can you talk about the time-based billing? And the other thing that I'd like to address is the day of requirement.
Yeah, so time refers to everything you did about that patient's visit that day, all the way from getting ready for the visit by reviewing your notes from last month or 3 months ago, reviewing what records came in, noticing in the medical record system that somebody else has seen the patient recently, and you're trying to figure out, why did rheumatology see them? Why did ophthalmology see them? And you read those notes. All the time that you spent on all those things counts as part of the sum of time. And the time that you are with the patient, and the time you spend with family or other person giving some of the history, like they came in with a caregiver, and all the time afterward. If your patient was seen by the resident and the resident presents the case to you, it's the time you spend with the patient case being presented that counts as your time. Resident time does not count. So you don't count anything about how much time a resident spent, nor a clinical nurse, an RN, or an LVN. Their time does not count. And your time counts until midnight that night. But at midnight, Cinderella's coach turns back to a pumpkin. If you do your notes the next day, that time does not count. A lot of time the residents are taking notes, but they haven't developed and sent you the note to be reviewed, edited, and signed until a day or two later. Unfortunately, that habit means that time does not get included in your sum of time that day.
I always just write a separate note on the same day, and then when the resident sends it to me, then my part is already done.
That's one way to get around the problem.
Rohit, do you have anything to add? There have been some recent changes, as you mentioned, in terms of what is required for different levels of billing. My personal favorite is that the review of systems is no longer required. Thank goodness. Are there any other things you want to point out?
Yeah, review of systems, bye-bye. I think that's my favorite thing too. So I think, 5 probably major changes I think we should just kind of quickly summarize. So first is that you do not require history and physical exam required for billing per se, but it is necessary indirectly to support your medical decision making. And now your level of visit is determined by either medical decision making or time spent, whichever is greater, but you do have to mention some history and physical exam to support that medical decision making. There were some previous requirements about needing to mention past medical history, family history, social history, review systems. We don't need to do that anymore explicitly for billing. There were certain strict criteria for HPI, such as the duration of a symptom, the acuity, the exacerbating and relieving factors. We don't need to do that for outpatient. We still need to do that for inpatient, but again, you still need to document whatever is required to support your medical decision making. So that's change number one. Change number two is, as we just touched upon, time that you include for patient care includes everything: chart review, obtaining history, exam, ordering tests, counseling the patient. The time need not be consecutive, and we need to include all time from midnight to midnight on the date of service. And the times that were previously used have also changed. For example, for a 99214, which is the level for established patient, previously that used to start at 25 minutes. Now it starts at 30 minutes. So there are some minor changes in that. There is also a prolonged service code that you can use in 15-minute increments after the level 5. It's a little bit tricky how to use that, but if you are someone who is spending a lot of time with the patient, you can use those prolonged service codes also. We don't have level 1 visits anymore. Everything is level 2, 3, 4, or 5. And as neurologists, as Dr. Newer pointed out, I think most of our visits would be level 4, some level 3. I think level 5 is a little bit difficult to achieve with medical decision making. It's fairly easy to achieve with time. The resident time that we spend discussing with the resident or the trainees, that can be included, but not the resident time that they're seeing the patient independently. And then the medical decision-making rules have changed. We talked about the number and complexity of problems addressed, which is the first element. Second element is the amount and or complexity of data that we reviewed and analyzed. And then the third is the risk of complications or morbidity and mortality from the management. And then the final billable level is decided by the two highest elements of medical decision making, or by the middle element if all the three elements are at different levels.
We talked a little bit about maximizing reimbursement, including same day completion, using your ICD codes to ensure that they are reimbursable, and also demonstrate the level of acuity that is the highest that you can for a particular patient. Are there any other tips and tricks, if you will, about maximizing reimbursement in your billing?
A good strategy might be to document time, regardless of what you assume might be counted in medical decision making might be correct or not. Sometimes you assume that it's going to be counted, but it's not. So, at least if you document the time, the billing and coding department can go by time and make changes at the back end if the time ends up being a higher level. And then, as Dr. Newer pointed out, please do please finish your note on the same day as the date of service, because as we all know, dictating or typing the note can take anywhere from 5 minutes to 20 minutes, and that will definitely increase your level of billing.
Mark, do you have anything to add?
One thing that we haven't specified is there is a modifier code if you involve a resident, and that is the code GC. The GC modifier does not affect the amount of money paid, but it is a requirement.
We've gone over a ton of things here in this podcast, and it's just the tip of the iceberg, I'm sure. How might our listeners learn more about billing?
Most universities or large hospitals will have a billing department that does periodic presentations and teaching. There are a lot of people around who understand the system and are available to help you understand how to improve. There also are presentations by national organizations. So your subspecialty society may have some teaching sessions at their national meeting or otherwise available online that address how best to do it for your own subspecialty. The national organization, American Academy of Neurology, also does seminars about billing and coding and management of a practice. Those all can be useful ways of understanding what you're doing. You also can purchase from AMA a copy of the CPT book. I don't know the cost, but it's not super expensive. Or you can go down to your local billing office and thumb through a copy of the CPT book. So you get some sense as to what are the rules about individual codes and what are some of the other codes that are available. Like there are codes for telephone calls, there's codes for emailing with patients, There's codes for comprehensive case management billed monthly for complex cases. And you really should learn about those, learn about which of those are actually paid by the local insurance companies, because you don't want to charge too many, let's say, telephone visits to a patient using the telephone codes when that carrier does not pay for them, and your patient is going to get upset that they're getting the bill themselves.
I would strongly suggest everyone to kind of spend some time reviewing the medical decision-making criteria and the time. You know, it's can be tricky. I think if you make a habit of using the criteria for every patient that you see in clinic, I think over time it becomes a second nature. And keep in mind some common scenarios that you see in your clinic, and you will automatically know what that billing is going to be. For example, in my practice, I commonly see patients with uncontrolled seizures where I'm changing a medication. That is a level 4. I just know that now, and I don't need to look at that MDM table again and again. But I should say that have that MDM table handy. That's what we do in our practice. It's in every clinic room, and I occasionally need to refer to it also. I think of it as a gamification, a puzzle. We are neurologists. We are supposed to like puzzles. That's how I kind of think about this.
Billing is fun. Not to end on a sour note here, but what might happen if somebody is billing inappropriately? Rohit, you mentioned that there might be some emails or messages from the billing and coding department asking for clarifications or changes in the ICD-10 codes. I've certainly gotten those. Are there audits or some type of process to make sure that a physician is billing properly?
Yes, there are auditors out there. If you bill everything at level 5 all the time, that is going to come up as a red flag in the insurance company, and they're going to question whether you really should be billing 98% of your visits as level 5. So they'll ask for 20 of your notes, and they'll look through them and see whether your notes justify level 5. If all your notes say total time today for an established patient, 40 or 45 minutes, you should pass the audit. It also should be honestly reflecting what actually happened. You can't be saying I spent 40 minutes when you actually only spent 30 or 20. Auditors have been known to request copies of your clinic schedule, so that if you're seeing one patient every 20 minutes and you bill all of them as 40 minutes, you're in deep trouble.
Got it. Keeping us honest.
Yeah, it's like taxes. You should bill for every single thing that you do, but not a minute more.
Well, thank you both for giving us this wonderful overview of this mammoth topic. We will be covering procedures and inpatient billing in other podcasts, but this was a great overview of outpatient billing for clinic visits. Thank you very much.
You're welcome.
Thank you.
Neurology Nuts and Bolts podcast was created and produced by myself, Sarah Schaefer. This podcast is not recorded as an official podcast of any institution or organization. The podcast is unfunded. Opinions are those of the individual participants. Music by Audrey Knapp, artwork by Shivani Ghoshal. Want more content like this? Be sure to subscribe to the Neurology Nuts and Bolts podcast wherever you get your podcasts to hear more about constructing your career in neurology. Follow us on Twitter at NeuroBolts and on Facebook at Neurology Nuts and Bolts to stay up to date on new content and give us feedback on what you want to hear, and tell your friends. Thanks for joining us.